Okay, hello everyone. We are on to our next chapter, which is biofeedback. I put this chapter with electrical stimulation because, especially when we're talking about our muscle reeducation e-stim, this is a really good tangent modality to use with trying to regain neuromuscular control. Um, it also, as we're speaking of electricity and neural pathways in the body, it just kind of makes sense in my head to put these two together. So this is one of the competencies in the e-stim packet for you to be working on. So biofeedback, what is it? It's basically, if you kind of break down biofeedback, right, it's the idea that you are giving feedback to the individual, or the individual is getting feedback on some sort of biological function in their body. Most of the time, we are talking about muscle feedback in this case. So why or how is it used? I think one of the most important pieces here is to think about biofeedback as an adjunct tool. So it's a training tool. Okay, the idea being that if we can help the individual realize when they are using or not using a certain pathway, neural pathway the most, it can help them then train in a manner that allows them to use that muscle without the biofeedback. That should always be the goal, is that you're trying to get them to activity without feedback. So just like when we did the e-stim for our neuromuscular reeducation, you do your 10 to 15 reps with the machine, but you're making sure that they are trying to contract without the machine so that they can make those pathways. Same thing with feedback. We're going to do a couple sessions with feedback, but then we're going to take the feedback off and see if they can recreate, because that's what's going to regenerate some of those neural pathways. And this is just kind of a fun question of why is it a modality? So based on what I've said so far, this is going to be one of your posts that you'll have to do, is why you think biofeedback is included in modalities. Okay? So when we kind of break down biofeedback, we're talking about giving feedback, information that the patient receives after or based on emotion or an activity that he or she has performed. So it's essentially information received following an event. And again, with biofeedback relating specifically to some sort of biological function. It can be intrinsic, meaning something that they get from within their body themselves, or extrinsic, meaning that they receive the feedback externally. So sources of biofeedback are really broad. We have the biofeedback machines, which is what you're going to learn how to use, which give visual and auditory feedback. There's more advanced, what we call EMG biofeedback, which is usually what's done in research, where individuals can see more of a graph of their muscle electrical activity. Pain is a source of feedback, right? So pain within the body tells you, hey, I'm doing something right or I'm doing something wrong. That would be an intrinsic form of biofeedback. Video cameras, recording someone. You guys did a motion analysis project, right, for kinesiology. That, if you then viewed that with the individual, they would get biofeedback on their motions and how they're doing that particular movement pattern. Mirrors. We've had people do squats or activities in the mirror so that they can see the motion that they have, especially in their knee, right? Watching for that valgus. And then you as an athletic trainer are a source of feedback, right? When you correct a motion, or when you use your hands to help guide a motion, that's giving biofeedback to that individual. Even when we're doing our e-stim and trying to create those muscle contractions, some tapping, some stroking of that muscle can help send those A beta signals that help then bring activity and attention to that area. So you can provide feedback in that manner. Coaches provide feedback, right? They again correct and work with movement patterns. So all those are sources of feedback. Patient can make changes based on the feedback. That's really important. So it does no good to have the feedback if they can't translate the feedback into improved function or differences in contraction or whatever it might be. So you want to train the patient. This isn't meant that we do the motion always with the feedback on, right? Eventually it's to get them back to doing this either on their own or even subconsciously, but that we've trained them into that motion pattern. So we're specifically going to focus on electromyographical biofeedback, which is the recording of electrical activity that's generated in a muscle. And we're using this for diagnostic purposes, right? We're trying to make interpretation from the electrical activity to the amount of motor neurons being stimulated in the muscle that we are targeting in order to kind of, again, help train the individual to contract that muscle more completely. And so what we're going to get as a readout of this is what we call an electromyogram, which is a representation of the activity. So again, if you're doing more advanced biofeedback with an EMG, you would actually get potentially a graph that shows the increase in electrical activity and how that comes on and how that plays out, and you can see that in graph form. We're going to be able to see it in the form of lights or hear it in the form of auditory response. So the instrumentation that we use all have similar qualities that you need to make sure that your device can perform. And so we call that monitoring, quantifying, and interpreting. So you have to have some ability to monitor the activity as well as then quantify it, and then you and the patient have to have some way to interpret what that means into action. So for some physiological activity, event, we're going to try to monitor, quantify, and interpret it. The reading should be a convenient indication of the physiological process, but it's really important to understand that it's not the process itself. So when we're talking about measuring electrical activity in the muscle, that's what we're doing. We're measuring electrical activity. We are not measuring strength of the muscle contraction. Though we can make inference that if we have increased electrical activity, that means more motor neurons being stimulated, which then should mean increased strength. So we make those interpretations, right? The third part of our diagram there, but we're not directly measuring strength. We're measuring the electrical activity, and we have to go through kind of a two-step inference process to get over towards muscular strength. So I have up there monitoring versus measuring, and your book talks about this as well. Monitoring involves determining whether neuromuscular activity is present, and if so, whether it is increasing or decreasing. Okay, so finding the electrical activity and then being able to tell if it's increasing or decreasing is monitoring. Measuring is measuring the activity involves placing it on an objective scale so that the monitored readout would actually have a scale that then, 5 means something on this scale, and a drop to 4 or drop to 6 are equally spaced. So the scale on a biofeedback unit may use the number of microvolts. It might be a simple 0 to 10. It might be a bar graph, other representation of the measure. So some machines measure where you can get an actual measurement. Other machines just monitor where we can get the increase or decrease. And for the most part, the machine we use is more of a monitoring device. We get that increase in the lights or the sound based on the increase, but it's very hard to quantify objectively whether 4 lights means a certain microvolt and 5 lights means a different microvolt. Other machines, you can do that a little bit clearer. Now we can quantify it in that we know we're getting more or we're getting less based on the monitored readout, but we can't necessarily give a direct number to it. So types of biofeedback that are out there. So again, we're going to do the electromyographical EMG, which is the most common, where we're measuring the electrical activity in the skeletal muscle. So that's what we're going to focus on. But I did want to point out that there's all these other ones out there. Peripheral skin temperature. So it's an indirect measure of the diameter of the peripheral blood vessels. And so it responds to stress or fear. Finger photo transmission units. So they do peripheral vasoconstriction. So they put light through the fingertip, a lot like a pulse ox machine would, and it measures the amount of light and how long it takes that light to get to the other sensor. And so if blood vessels are dilated, less light's going to be able to get through than when they're constricted. And so vasodilation indicates work is happening, right? We've increased the dilation into that area, so work is taking place. Skin conductance, we can deal with when people sweat. And so when you sweat, there's salts. Salts make for better transmission of electricity. So you send a little current along the skin, and if the current is moving faster and more conductant, then you know that they're sweating, which again is an indication of work. So sweaty skin is going to be more conductive. Pressure changes. This is kind of a fun one. So you can actually use a blood pressure cuff. So a sphygmometer, right? Blood pressure cuff to measure pressure changes due to muscle activity. And so we do this a lot when we're trying to get people to start to brace and use their core. We can inflate the blood pressure cuff to a certain level and place it under them, and then as we ask them to brace, they should be able to increase the pressure that you read on the sphygmometer and see that they're actually bracing appropriately and effectively. And then the electromyographic that we'll be dealing with. So these are just images of various ones. So here's the blood pressure cuff. This is the skin conductance. This is more of the EMG, where they actually have fine needle electrodes, so they're inserted into the skin. This is a nerve conduction velocity, which is another way to measure. We have isokinetic dynamometer, so a biodex machine where we can do rehab and things like that on it, but we could also measure strength, and we would see a diagram on the screen. Here's just another set of biofeedback, and then this is going to be what we use, which is the portable biofeedback units. So a little physiology review of the muscle, okay, before we move on. So remember that the axon of a motor unit conducts an action potential to the neuromuscular junction, where the neurotransmitter is released. The neurotransmitter then binds to the receptor site on the sacrolemma, which depolarizes the entire muscle fiber. And it moves in both directions up and down the muscle fiber, the transmission, creating a movement of ions and an electrochemical gradient around that muscle fiber. And remember, a motor unit is one motor nerve to multiple muscle fibers. So motor unit tension is determined by the number of active motor units. And motor units are recruited based on the force required in an activity and not the type of contraction. So usually we start by, right, our body doesn't want to burn itself out. So we start with the slow twitch, and then if the force is great enough, then we move on into our fast twitch. And so that order is going to happen. Now remember, when we were talking about E-stim, we actually reversed that order when we were trying to electrically induce the muscle contraction. But we're not doing that in biofeedback. We're having them perform the contractions. So it's going to start with those slow twitch and kind of low energy fibers, and then eventually go into the fast twitch if we're asking and demanding more force out of them. So the speed of contraction is also influenced by the motor unit. So how quickly do we have to get up to that force needed? And so as we need faster, we're going to increase the number of motor units, and they're also going to increase to more of the type 2 fast twitch muscle fibers. So the changes in the potential difference or the voltage associated with that depolarization is what we can detect using an electrode put in close proximity to the muscle. So that's what we're going to measure, is that depolarization. So in theory, we're getting more depolarization, okay, which means more electrical activity with the more motor units that we're recruiting. So that's where we get that interpretation or that inference that eventually we're leading to a stronger, more viable muscle contraction if we can see increased electrical activity. And so electromyographical biofeedback measures the electrical activity under the electrodes. Okay, so electromyographical biofeedback. We then interpret that electrical activity as muscle activity. Okay. So how do we measure that muscle activity? It does not measure muscle contraction or strength directly. That's what I mentioned before, right? So we are measuring the electrical activity, but not the strength directly, though it'll be similar, or the inference is there. We measure it usually in microvolts, and we're trying to detect changes in the electrical activity in the skin, or through the skin via our electrodes. So the changes can't be quantified. It's all comparable. So again, with our devices, we're not getting a numbered readout in volts. So there's no standardized measurement scale. There can be when you're doing the more advanced EMG type of electromyographical biofeedback, but with ours, we can't quantify that. So we have to always use the same equipment if we want to be able to compare. We'd have to use the same device. We'd have to put the pads on in the exact same places to be able to compare. But for the most part, our goal is really not necessarily to quantify that muscle strength, but to get the person to be able to produce the muscle activity better. And so it doesn't necessarily matter day to day if we can really compare. The patient might want to get a few more lights on that readout or hear the tone a little bit faster. But for the most part, if we're seeing the progress and them being able to control the muscle contraction on their own without the feedback, it doesn't necessarily matter if we can compare. So another thing to kind of note is that we have to, when we're measuring electrical activities, we have to separate the noise from the desired electrical activity. So when we measure muscle contraction, we need 2 active electrodes in close proximity. They're in a bipolar arrangement. And then we have a third electrode, which is going to pick up the signal of what we call noise. Okay, and it's what we call a reference electrode. So we're going to be able to cancel out whatever activity that reference electrode picks up as just normal body electrical activity. And then anything beyond that normal, what we call noise, just natural electrical activity, that's then going to be interpreted to be that increase in the electrical activity because of the muscle action. So we're going to get 2 signals from the active electrodes, and we're going to compare those to the references, and then any common signal is going to be canceled out. And with it goes that extraneous noise. Now when you're doing EMG and getting the actual graphical readout, then it needs to be filtered. And so it gets run through filtered to become what's known as a raw EMG, and then rectified, smoothed, and integrated for a final signal. You don't have to worry about that if you get into more advanced biomechanics. If you go to school for exercise physiology, or I did some EMG work for my master's thesis in grad school, you'll maybe use more of the advanced EMGs and have to know your equations and such to rectify your signal, but we don't have to for our portable units. So looking at the biofeedback equipment that we're going to use, the most important thing is your electrode. So for the most part, we're using one-time use electrodes, okay? We're going to use skin surface. We're not going to use the fine wire. Fine wire actually get embedded into the skin, into the muscle belly itself. We're going to just use surface electrodes. They're usually nickel-plated, brass or gold or silver. Ours are silver chloride. They come in various sizes, and then they usually come with a conducting gel or paste. So you have to put a little gel on the electrode itself, but the electrode is sticky. So this is what ours actually look like. So you have the 3 electrodes, you have the 2 active electrodes, and then the reference electrode. Okay, so these 2 are going to go and line up with the muscle belly itself this is going to be your reference electrode. So the two active electrodes measure the amount of electrical activity. The third is our reference. We have to skin prep just like we did to put on our pads. So you need to get rid of all the oiled and dead skin and excess hair. So we want to use an alcohol swab to wipe all that off. When you're doing really true EMG work, you usually also abrade. You take some emery paper and kind of abrade the area. You usually shave the area. And then obviously if you're doing the fine wire, you actually inject into the body and into the muscle belly. But we'll just use alcohol swabs for now. But if you were doing this multiple times on someone, you'd probably have them shave that area so that you get a better signal. Then to place the electrode, we're going to place it as near to the muscle being monitored as possible. So again, get those active electrodes, usually in the muscle belly or over a motor point. So you can use your motor point reference to look at that as well. You want it secured down because you don't want any movement of the skin to change the electrical activity that you're getting a read. You want it to go parallel with the muscle fibers. So you want the, just like when we did our E-stim setups, we want it to be parallel with the muscle fibers. And as the distance between would increase, the signal from the activity of nearby muscles would as well. That's why these are really close together, because we want to just get that muscle activity. We don't want to get all the muscle activity all around it.